Dr. Devaprasad ji, please, you can take on the class.
Thank you, Farz Academy and all the moderators for inviting us here. This would be taken by Dr. Sindhu Vallari, who works in our unit, and she will lead the case-based discussion. We would interrupt intermittently with some questions if necessary to understand some aspects, and we'll encourage all of you to question her so that at the end of it, we'll all be clear with the topic that we're discussing today. Uh, Dr. Sindhu, can you please start your presentation, please?
So I'll be welcoming all the today's esteemed moderator Banambar sir and Dr. Devapriya. So whoever have any questions, please I request them all of them to put in the chat box. And I think Banambar sir will be the esteemed moderator today. So sir will answer few questions, of course, with Dr. Devaprasad. And now we'll start. Thank you very much.
Good evening, everyone. So I'm going to discuss about a case today. So this is about a patient we received. She's a 62-year-old female. She's a known patient, a known case of diabetes, hypertension, and hypothyroidism, and she's on regular medications for that. She was brought to the hospital with the complaints of sudden onset, involuntary movements of all the four limbs, which lasted for around 2 minutes, and again associated with the urinary incontinence. On arrival to the hospital, she's conscious but a bit confused, and her vitals wise, she's maintaining the saturation on the room air. Her BP was fine, 110/70, and her blood glucose is fine, 156 mg per deciliter. She's afebrile, and examination wise, there are no oral secretions, no evidence of any tongue bite. Neurological examination wise, her GCS is E4 V4 M6, just confused, and over a few minutes, around within an hour, her GCS came to be 15/15. Pupils were bilaterally equally reacting to the light, and no evident focal neurological deficit.
Dr. Sindhu, what are your differential diagnoses at this point?
Yes, sir. When since her GCS gradually rapidly improved, we're thinking of any new onset seizures, any stroke at this age, or hemorrhage in the brain. It could be any metabolic causes, toxins or drug-induced seizures, and finally could be a trauma.
Okay, when you're talking about metabolic causes, what metabolic causes are you considering?
Yes, she was a diabetic, her blood glucose is fine. So could be that any dyselectrolytemia can cause this seizures. So hyponatremia.
Okay, so you're talking about hypoglycemia induced seizures. Does
Yes.
hyperglycemia also induce seizures?
Yes, can happen, but sugars are fine. Yes, sir, can happen.
Can happen. So you're talking about this electrolytemia. Which electrolytes are you really concerned about?
Sodium, sir.
Sodium. Can calcium calcium also cause seizures?
Yes, sir. Hypocalcemia can cause. Yes, sir.
Okay, hypercalcemia also in extremes can cause seizures. Okay, so you're talking about stroke and hemorrhage as well, toxins and trauma.
Yes,
Okay,
sir. Yes, sir.
so what will be your immediate plan of care for this patient?
Yes, sir. Immediately, so general thing initially, if there is any, it's always ABCD. So we'll stabilize the patient first. So if there is any, for this patient, she's maintaining the airway, and BP is fine. If not, we need to first secure the airway, and BP and GCS continuous monitoring should be there. And as I already said, we need to see how our electrolytes are, whether there any source of any infection, everything we need to send for the samples. And then for specific management, so since she presented with seizures, we need to load her with anti-epileptic agent. So we in this case we loaded her with levetiracetam, and then if they are having any pain, we can load with analgesics, and then immediately we have to go for non-contrast CT brain scan.
Okay, what makes
So
you think? What makes you think the airway is patent?
Her GCS rapidly improved. She's 15/15, maintaining the airway in room. Saturation is normal in room air, sir.
So you were able to speak to her. She was able to speak to you.
Yes, sir. Yes, sir. Yes, sir.
So that's one way. And then you're also looking at GCS. You said you're looking at CBC electrolytes, urea creatinine, etc., anti-epileptic agents, and you said you gave her levetiracetam. How much levetiracetam did you
Yes.
give?
For her, 1.5 grams were given, sir.
1.5 grams stat. Okay, why did you not consider giving lorazepam at this point of time?
She's not actively seizing.
Okay. So she's not in a patient. So when do you consider to give lorazepam?
When the patient is actively seizing, that would be the drug of choice, initial first drug of choice.
Okay. So okay. Now suppose this patient had not regained a consciousness, and
Okay,
then
sir.
she had presented with seizures. Then what would be your thought?
So we need to think of any non-convulsive seizures also should be kept in mind, or it could be a post-ictal confusion, post-ictal state also, but non-convulsive seizures should be kept in mind.
Okay. Just to specifically say, if a patient does not regain consciousness in 5 minutes, yeah, it could be a prolonged post-ictal, but always rule out non-convulsive status in these patients and treat them as if they have non-convulsive status. That's the point. Okay, please proceed. You asked for a non-contrast CT.
Yes.
Any particular specific thing that you would ask your radiologist to look at, or you would also look at?
Yes. For her, we need to think of a stroke. It could be either ischemic or hemorrhagic. So we need to look for any hemorrhages or a infarct or
Okay.
any space occupying lesions.
Okay, considering especially she's got a seizure. Okay, okay then. Okay, please proceed.